I just want to introduce our next speaker, and it's Dr. Murugan, Dr. Paari Murugan, who is the current director in surgical pathology here at the university. He's a board-certified anatomic pathologist specializing in genitourinary and soft tissue and bone tumors. He's an MD graduate at Madras Medical College, and did his AP residency at the University of Oklahoma Health Sciences Center, and that was followed by fellowship in oncology pathology at MD Anderson Cancer Center, and then the GU pathology that he did at Memorial Sloan Kettering Cancer Center. He's a member of the College of American Pathologist Cancer Committee, and he co-authored as part of that committee multiple genitourinary soft tissue and bone cancer reporting protocols. So beyond his clinical diagnostic expertise, he is also actively involved in resident fellow education and translation research. He received multiple Best Teacher Awards over the years, authored many papers, over 95 papers that were peer-reviewed, and has contributed to several NIH grants. So please welcome Dr. Murugan. Thank you.
Thanks a lot, Emil. I usually start off this slide with describing our campus and this magnificent river that flows across it, but this audience probably doesn't need any introduction. So just move on to the next slide. I don't have any disclosures other than the fact that I'm not going to talk a single word about artificial intelligence or digital pathology. So rest assured, it's going to be all very, very traditional. I'm not going to go into too much detail about the how IHC started and all that, but just briefly, IHC as such, or I should say, recognition of antigens by antibodies and observing it in tissue, that started long time ago. In fact, back in the 1940s, when Kuhn's first described immunofluorescence, that's like a direct antigen antibody reaction with the fluorescent dye detected on tissue. But it took a long time after that, maybe about 50 years or so. It was not till the 1990s that we actually started doing diagnostic immunohistochemistry on FFPE tissue. We did have advances that led to that, but I think one of the key advances was you needed good antigen retrieval techniques on FFPE tissue, and those were performed in a robust manner only like in the early 1990s. So when that happened, what I'd like to call as first generation IHC markers, we had some broad differentiation markers. All of you are very familiar with these markers. So keratin for epithelial tissue, vimentin for general mesenchymal tissue, and then some specific markers like Desmin, S100, etc. So and then in the 2000s, we became a lot better. We had some organ and lineage specific markers, and of these, the nuclear transcription factors were the ones that proved most helpful in our differential diagnosis because they were easy to read and the non-specific staining was limited and there was nuclear reactivity for all these. So you know about PAX8, GATA3, and TTF1, etc. But I want to talk today about what some people like to call as next generation IHCs. So these are novel, highly specific and sensitive antibodies to antigens, and they are expressed in highly restricted tumor types, meaning only in a few tumor types, ideally a single tumor type, or at the most 2 or 3 tumor types. And importantly, they have negative or very low level expression in normal adult tissue. This is because they directly detect the protein products of genetic abnormalities that lead to the formation of the tumor. So these abnormalities can be like a mutation or an amplification or a fusion. And these obviously are really good surrogates for molecular testing. And we are using many of these as part of companion diagnostics. Again, the ones that you might be familiar with across all organ systems, you got P53, HER2, and then IDH1, the R132H for gliomas, the BRAF, etc. And then I also like to include to the next generation IHCs protein products that are a result of upregulated genes that are downstream of the actual genetic abnormality that drives the tumor growth. So I'll show you some examples of these, but I think these belong to the next generation of IHC markers as well. So one of the specialties, or I should say, by far the most profoundly impacted subspecialty in surgical pathology when we started using these next generation IHCs is the field of soft tissue and bone pathology. And there are numerous markers that came into practice in the last 10 to 20 years. And I've classified these into two groups. One is the older group, perhaps the antibodies we started using about 10 years ago or more, and then the antibodies that are fairly newer in the 2020s or starting 2015 and onwards. And then the other classification that is useful in trying to understand how these things work is by putting them into these three major buckets. So in the world of soft tissue bone pathology, there are a lot of tumors that are driven by specific fusions. So this bucket is by far the largest bucket that we have in terms of the next generation diagnostic IHCs. So these fusion proteins, all of you are familiar with things like STAT6 or ALK, and some of the relatively newer ones like CAMTA1 for EHE. And then we also have antibodies that are based off of mutations and the protein products resulting from the mutation. So in this case, the first one, INI1, it results from the loss of or mutation in the SMARCB1 gene, which leads to loss of the INI1 proteins. And prime example here being epithelioid sarcoma, and then upregulated proteins, which are due to, as I mentioned earlier, secondary protein products from gene upregulation that may or may not be directly related to the genetic event that's driving the tumor. And a prime example here would be DOG1 for GIS and MUC4 that we used on a consistent basis these days for the diagnosis of LGFMS. And then the second group, the ones that I was mentioning that was like in the last 5 years or 10 years perhaps, are the newer next generation IHCs. So NTRK, the pan-TRK antibody must be familiar to most of you. So these detect pretty much all the tumors that have the TRK fusions, TRK1, 2, 3, NTRK 1, 2, 3 fusions. And then we also have some newer antibodies in this category, including DDIT3 for myxoid liposarcoma and FOXO1 for alveolar rhabdomyosarcoma. And there are some mutation-associated proteins as well. And in bone tumors, we have some of these histone mutation-associated antibodies that are extremely useful in making the diagnosis because they are very specific. So here's one example, the H3K36M for chondroblastoma. And there's another one for giant cell tumors that I will talk briefly about later on. And then in terms of upregulated proteins, we have ETB4 for CIC rearranged sarcomas. And then one of the newer ones is CADM3, that's exquisitely sensitive and specific for the superficial CD34 positive pleomorphic fibroblastic tumor. So you might have noticed that that this list is not a complete list of all the antibodies that we have in our armamentarium right now for the soft tissue bone tumors. There are a lot more, and I haven't covered all of them, of course, but I will try to cover some of the ones that I have not mentioned in these tables by using some case studies that we came across in our practice that were really helpful in coming to a correct diagnosis on challenging and difficult cases. So I have 5 such case studies, and we can start with case 1. So this was a 10-year-old male patient, and this patient had a mass in the back of the knee that you can see over here. It's closely related to the joint, but it doesn't seem to be coming off of the joint as such. There is some separation. The radiologist did mention that it's a purely cystic mass. It's more or less homogeneous, and it also seems to be associated with the tibial nerve over here. So their differential diagnosis was this could be a tracking synovial cyst. Sometimes what happens is the synovial cyst leaks out of the joint, and then it over time separates from the joint itself and forms a mass. We've seen that in the popliteal muscles a few times. So that was one of the differential diagnoses, and you can have schwannomas that undergo cystic change because there is close association with the nerve. That was in the differential diagnosis, and they also put in a cystic malignancy over there. Our surgeons thought that this was quite benign in appearance, so they decided to, instead of doing a needle biopsy, they decided to just do a frozen and sort of an open biopsy during the surgical procedure itself. And this is what we saw during the frozen section. You can see that it's predominantly cystic. It's got these cyst wall structures, as was described by the radiologist. It looks fairly hypocellular. There's also a collagenous background, perhaps some edema, but this could also be frozen artifact. The cellularity, even on high power, wasn't too much. You can see an area of hyalinization here with some hemorrhage, and these bland appearing spindle cells mixed in with some inflammation. So this was called benign something, no clear evidence of malignancy, and this tumor was resected in the same sitting. And this is another one of the sections that shows you the cystic change. Perhaps there is some increased cellularity in this cyst wall over here. Many different antibodies were used, many different IHCs. All of them turned out to be negative. The only one that showed some positivity was the CD99. But as we know, that doesn't really help too much in coming to an accurate diagnosis because that's quite nonspecific. However, one other antibody that did trigger further investigation in this particular case was our usual cytokeratin A1, pankeratin A1, A3. It doesn't seem like too much over here. Maybe you don't see anything there up on the screen, but there are focal cells that do seem to show some reactivity. This could be non-specific reactivity, or it could mean something else. And the follow-up stain here was SS18 SSX, which does show robust reactivity in many of these spindled nuclei. Not all of them, probably because many of them were fibroblastic nuclei, but a substantial amount of spindled nuclei are positive for SS18 SSX. And then we also have the companion stain, the SSXC, which was showing a similar amount of positive nuclei. So this is a case of a cystic synovial sarcoma, deceptively bland appearing, and could easily be misdiagnosed as a benign tumor, as was unfortunately done during the frozen section procedure. But the patient did okay because this tumor was more or less completely resected, and he received radiation and has not experienced a recurrence till now. So let's talk a little bit about SSX18 and SSX. So this antibody is a little bit different from all the other next generation antibodies that we have that are targeted towards the fusion genes because this is ingeniously designed to straddle the fusion gene itself. Like it's got some amino acids on the SSX18 side and some amino acids on the SSXX side, and the antibody actually straddles both. So it's quite specific. So what does SSX18, SS18, SSX do to cause the tumor? It basically replaces the wild type SS18, which is part of the SWI/SNF chromatin remodeling complex. And sometimes this also affects the SMARCB1, which is part of the same complex. And that's why you also see INI1 loss in some of the synovial sarcomas. And because of this, there is epigenetic dysregulation and then altered gene expression due to that and malignant transformation. So as I was saying, this antibody targets the breakpoint amino acid sequence, as you can see over here. And then just to have a fail-safe, just in case the breakpoint could be somewhat different in some synovial sarcomas, we also have a antibody directed against the SSX C-terminus tail. So this should increase the sensitivity of this marker. So the combined specificity and sensitivity for SSX18 SSX is greater than 95%. So we always use these two antibodies in combination. And the primary antibody, the 18 SSX, is 100% specific because it's just synovial sarcoma that shows this specific fusion as of today. And in terms of sensitivity, it is slightly less sensitive than 100% because there could be variant breakpoints here. And like I said, that's where the SSXC is helpful. And in fact, this antibody combination is so powerful that it's more sensitive than FISH. In our practice, we stopped doing FISH for all suspected cases of synovial sarcoma. We just use these antibodies. You can have other tumors that show some reactivity for this antibody, but I'm talking in particular about SSXC, not about the SSX18 SSX, because that's 100% specific, as I said. And we have seen some dedifferentiated liposarcomas and malignant peripheral nerve sheath tumor that can pick up some SSXC. Other tumors have been described in the literature as being positive for SSXC. But I'm not sure if that's going to be as robustly and diffusely positive as we see in synovial sarcoma. So here is one of the cases that we encountered in our practice. This is dedifferentiated liposarcoma with epithelioid and pleomorphic morphology. And this case did show some reactivity for SSXC. It was patchy, but many of the nuclei exhibited a strong reactivity. However, the differentiation between synovial sarcoma and dedifferentiated liposarcoma is not really that difficult to make because typically, unlike synovial sarcoma, the dedifferentiated LPS occur in older patients and they prefer the retroperitoneum. And unlike synovial sarcoma, which are almost always monotonous in nuclear morphology, these tend to be pleomorphic. Unless you, of course, have a poorly differentiated synovial sarcoma. And you can also see in many cases an interface of the dedifferentiated component with well-differentiated lipoma, atypical lipoma-like components. And then, of course, if you do SSX18 SSX, that's going to be negative in these tumors, as we saw in this case. And we also like MDM2 in this setting. In dedifferentiated liposarcoma, MDM2 is quite powerful because it tends to mark it in a diffuse and strong fashion. So with that, I want to transition to case 2. This is in 2 parts. First part is a 28-year-old patient with a posterior knee mass that you see on the X-ray over here. And the radiologist described it as a heterogeneous calcified mass that was arising from the distal femur. So this patient happened to have a diagnosis elsewhere, and based on that, the radiologists agreed that it's consistent with the histologic diagnosis of an osteochondroma, perhaps a sessile one. So we reviewed this case, and this is what we saw. You can see on a low power, it does look somewhat like an osteochondroma. You got a cartilaginous cap over here, and then you have some bony trabeculae coming off of it, like enchondral ossification, and perhaps some marrow tissue in between the bony trabeculae. And there's also some perichondrium or periosteum over here that appears thickened. So closer observation, though, reveals some puzzling features. Here, the cartilaginous cap seemed to be disorganized, and there seemed to be some hyperchromatic nuclei in here, although it's difficult to appreciate. And in between the bony trabeculae, it's not actually marrow tissue, as you would expect to see in an osteochondroma, but it appears as if there is a fibrous transformation of the stroma. And then if we take a closer look at the perichondrium or the perichondrial periosteal fibrous tissue itself, first of all, we could see from the low magnification that it was quite thickened and somewhat abnormal looking. But when you look at it closely, the cytology itself is not so bad. It appears quite bland. However, because of these unusual features, it triggered us doing this stain, which is MDM2. Even in a partially decalcified specimen, you can see it works really well. And all of these spindle nuclei show this type of diffuse and strong reactivity. And not just in between the bony trabeculae, we also saw this type of robust, undeniable diffuse reactivity in the perichondrial fibrous tissue. So this tells us there is only one diagnosis for this case, and that's a parosteal osteosarcoma. And of course, we always need to correlate with the radiological impression in these cases. And the posterior knee, the distal part of the femur in patients who are on the third decade, that's the prototypical description of a parosteal osteosarcoma. And in fact, when we got the resection specimen, you can see that the cartilage indeed does look abnormal over here on the left. Although the bony trabeculae, again, it doesn't really look like what you would expect in a malignancy. Some of you might think, okay, this looks like a fibrous dysplasia, and that's right. Parosteal or low-grade osteosarcoma often mimics a fibrous dysplasia appearance, and one has to be really careful in this setting. And even in this specimen, again, it was decalcified, but you can see there are at least a few robustly staining spindle nuclei in the fibrous stroma for MDM2, which proves, again, that this is indeed parosteal osteosarcoma. So before I talk more about MDM2, I want to talk about the second part of this case, which is a 72-year-old male patient with chest pain. And the pain was not because of his heart, it was because of this mass that was located in between the pectoralis major and minor muscles. The mass as such looks fairly well circumscribed, somewhat heterogeneous, and it doesn't really have any particular features about it that would help a radiologist make a diagnosis. So they basically said it could be a benign or a malignant neoplasm, and our interventional radiologist put a needle through it, and this is what we saw. This is a robust biopsy where you can see both hypocellular and hypercellular areas over here. There seems to be some fat over here and probably some skeletal muscle entrapped fibers over here. So nothing specific on the low power. On the higher magnification image, we can see that this is a spindle cell neoplasm, moderately cellular collagenous background. probably some inflammation or some nuclear apoptotic debris. And there are also some hyperchromatic nuclei that are scattered in between all those spindle cells. So the hypocellular areas, again, showed this fat and maybe some scattered hyperchromatic spindle cells. So that was the higher magnification image. So this looks like any generic sarcoma subtype. We'd need some immunohistochemical workup to see what's going on here. So in this particular case, multiple immunohistochemical stains were performed, and all of them proved to be negative till we did this one. Again, this is MDM2. Again, you should notice the unequivocal, robust, diffuse, strong staining of pretty much all the nuclei that we see over here. So this proves that this is a dedifferentiated liposarcoma, and we have further proof. So because we do understand that MDM2 can show reactivity in other high-grade sarcomas as well. But in this particular patient, this was the resection specimen after he got radiation. And in the resection specimen, you can clearly see some of the heterogeneous areas that the radiologists were talking about was actually fat. And there's an interface between the fatty component and the more cellular component, just like we would expect to see in a dedifferentiated liposarcoma. And a closer look actually shows these hyperchromatic enlarged nuclei intimately associated with the mature adipose tissue, just as we would see in an atypical lipomatous tumor. And MDM2 performed in this section also reveals a really dark nuclear reactivity, which is consistent with a liposarcoma. So MDM2, this protein is overexpressed due to either gene amplification in most cases, or in some cases, it can be overexpressed due to transcriptional upregulation due to secondary events, like even P53 mutation can overexpress MDM2, and then it follows that negative feedback loop. So this is the key oncogenic mechanism that inhibits the P53 pathway, because MDM2 binds and degrades the P53, subjecting it to ubiquination, and this causes loss of P53-related tumor suppression, resulting in tumor growth. So as I was mentioning repeatedly, you need to see the strong staining in a significant proportion of tumor cells. When you see this pattern, it's highly specific for these tumors. And we often come across such staining. Like you can see that some of the mast cells in the background are the ones that are showing the dark staining. And if you observe carefully, this is not really nuclear staining, but it's cytoplasmic. And the tumor cells in the background do show some reactivity, but it's weaker and granular in nature, not the complete dark staining that we would expect to call it positive. So if you see, when we come across this pattern, we do not call this positive. And the sensitivity is quite high, but it depends on what tumor you're using it for. It does have variable sensitivity in well-differentiated liposarcomas, because some of these well-differentiated tumors show a low level of amplification that can be picked up accurately only by FISH testing or by NGS. So as I mentioned, there are other tumors that can be positive for MDM2, the most common one being MPNST and some high-grade myxofibrosarcomas or UPS. In terms of bone tumors, we were talking about the usefulness of MDM2 in the setting of low-grade or perosteal osteosarcoma. High-grade osteosarcoma is not really in the differential diagnosis in this setting, because obviously the nuclear features are helpful in making the diagnosis there, but it can be positive in up to perhaps 10% of high-grade osteosarcomas as well. And as you know, intimal sarcomas can be positive for MDM2. So there are a few tumors that are consistently positive for MDM2, and this is where it's diagnostically helpful. So those would be the low-grade osteosarcomas, the well-differentiated, dedifferentiated liposarcomas, and intimal sarcomas. We also found in our practice that SMARCB1 deficient sarcomas consistently overexpress MDM2 at a protein level, even though they don't really show the amplification. So in terms of the differential diagnosis, I just wanted to put up the prime example here, the MPNST. This is a case of MPNST that's involving the adipose tissue. So LPS, DDLPS might come into the differential diagnosis, and it also has sclerotic areas that you often see in liposarcomas. And MDM2 can show this type of strong nuclear reactivity, although you can see it's not in the entire tumor, it's just in this focal area. But it may not be that difficult to make a differential diagnosis or diagnose MPNST correctly in the setting if you get a robust biopsy like this. Most of these patients, up to 50% of patients with MPNST do have a history of neurofibromatosis type 1, so that's helpful. And the histology, to see that most MPNSTs tend to have this marbled appearance, the light and dark areas alternating. They also can have these tag-on vessels and perivascular condensation of the tumor nuclei. And there's also this phenomenon of endovascular protrusion of the tumor cells that are clearly present over here. You don't see this in all cases, but you can come across this phenomenon in some cases. And the nuclei, they tend to be spindled, elongated, and you might notice some nuclear buckling. So the histological features are somewhat helpful. And the IHC, MPNST can sometimes show patchy SOX10 or S100 reactivity, like for example in this particular case, and then many cases up to 70% of high-grade MPNSTs can show loss of H3K27 ME3 that might be useful in the setting to differentiate it from DDLPS. Okay, so that's about MDM2 in case 2. So case 3, if we move back to a bone tumor, this is a 47-year-old patient who had an incidental proximal humerus mass. So it's mixed, lucent, and sclerotic. The humeral head is involved. It's subarticular, and it's also extending into the tuberosities and a little bit into the proximal shaft. So the radiologist had a differential diagnosis of simple bone cyst and fibrous dysplasia. The surgeon wanted to consider an early stage of Paget disease as well. And we have an open biopsy. So fortunately, our surgeons do open biopsies in many of bone tumors because oftentimes it's really difficult, especially in cystic-looking bone tumors, to make a diagnosis of interventional radiology-guided needle biopsies. Unfortunately, though, this particular case had an open biopsy that bone pathologists really don't like at all. I mean, that's because you get this nondescript small fragments of bone, and then you get this hemorrhage and some sclerotic stroma and perhaps pockets of inflammation. I mean, like, what do you do with this? It's hard. So you look at it closer in one of the inflamed areas. There seems to be a hemorrhagic cyst over here, and then some hemosiderin pigmentation associated, and some bland-looking spindle cells. Another area shows also new bone formation, primitive osteoid. And if we take a closer look at this, we can see that there are some histiocytes, and then the background shows, again, chronic inflammation and some spindle cells that don't have any particular characteristics. So this type of stroma you can find in many, many bone tumors and reactive lesions in the bone. So this doesn't help at all in making a diagnosis of the morphology. However, we have this magic marker H3G34W, which was diffusely strongly positive in a majority of the cells, which nails down the diagnosis of giant cell tumor, despite the fact that we do not see any osteoclastic giant cells here at all. So this does happen occasionally. The clinical features, actually, the radiological clinical features actually fit. You have a patient of appropriate age, post-maturation, post-bone maturation, and you have the epiphyseal location with a lytic and somewhat sclerotic lesion that fits giant cell tumor. So this is another case where we had actually a needle biopsy this time. It doesn't show too much material, but we do have better tissue than we got in the previous case. If you look at this fragment closely, this one actually has a textbook picture of what you might see in a giant cell tumor of the bone. So evenly distributed or uniformly distributed multinucleated giant cells and a vascular stromal background. However, even this is not completely specific because the mere presence of a focal mere presence of giant cells in a bone tumor does not necessarily always equal to giant cell tumor of the bone. So G34H3G34W in this particular tumor also showed diffuse strong expression, helping us make the correct diagnosis. So what is this antigen, and what does the antibody directed against it do? So this actually detects the mutant histone H3.3 protein, which results from a specific point mutation, that is G34W, in the histone F3A gene. And this mutation is the principal driver mutation in giant cell tumor of the bone, and you don't find it in any other tumor. So this basically disrupts the normal post-translational modification of the histone. And as we know, the histone proteins are responsible for gene regulation too. So it causes impaired osteogenic differentiation and also produces chemokines that activate and attract osteoclasts to the site. And it's important to remember that this mutation and the corresponding antibody that picks up the mutated antigen is present only in the neoplastic mononuclear stromal cells and not in the osteoclast-like giant cells. And it has 100% specificity and quite high sensitivity for giant cell tumor of the bone. The sensitivity is not 100% because occasional giant cell tumor of the bone may have a rare variant in the mutation, like instead of G34W, it might have G34L or M or B, and these tumors are specifically found or more commonly found in the small bones where giant cell tumor itself is uncommon. You can also see it in patellar giant cell tumors. So basically 100% specificity, so no other tumors are positive for this marker, except if you want to consider a malignant giant cell tumor that does arise from giant cell tumors that acquire additional mutations. So here you do have a case of malignant giant cell tumor that basically looks like a telangiectatic osteosarcoma. And even in these cases, you will find focal areas that do look like a conventional giant cell tumor of the bone, like what you see over here, and the marker is diffusely strongly positive in malignant giant cell tumors as well. So quickly, how do you differentiate? The location and clinical features are, of course, similar, but the histology is not, because the malignant giant cell tumor shows a high degree of polymorphism atypia, and most of these cases were actually diagnosed as either UPS or high-grade osteosarcoma in the past before we had this marker. And even in these cases, if you look carefully, you should see some areas that show an osteoclast-rich presence, as you would see in a conventional giant cell tumor of bone. And this is the G34W marker in the malignant giant cell tumor that's positive. Right, so case 4, we move back to soft tissue, and this time it's a large mass in the retroperitoneum of a 50-year-old male. And this is 23 centimeters in size. You can see that over here. And radiologically, the differential diagnosis was quite expected in this location with such a mass. Liposarcoma and dedifferentiated liposarcomas are the primary differential diagnosis. So That was quite reasonable, but we had to make a histologic confirmation. So a needle biopsy was done. So this is what we saw in low-powered needle biopsy. Got two cores over here. One of the cores does look like predominantly composed of mature adipocytes. The other core shows some increased cellularity in between. So if you look at higher magnification on the the better differechinated side of the core, we do see variation in size of the adipocytes, and we also see scattered, enlarged hyperchromatic nuclei that we would expect to see in a well-differentiated liposarcoma. The higher magnification of the more cellular areas is more intriguing, though. So here you see there are some epithelioid cells that seem to be in cods, some clusters, nests, perhaps in a sclerotic stroma, and they seem to have a abundant cytoplasm, maybe plasmacytoid or rhabdoid appearance. So again, many different immunohistochemical markers were performed on this case. All of them were negative except for S100 over here, which did show some patchy reactivity, perhaps non-specific, but perhaps not. But at this point, as is the case in many cases, the H&E morphology on careful observation really helps you come to a better conclusion than applying multitudes of immunohistochemical markers. So if you look at some of these areas in the well-differentiated component, the atypical nuclei, they appear multilobated and multiple fragments of nuclei. And also the cytoplasm appears eosinophilic, somewhat reticular, somewhat fibrillary. This is unusual in a well-diff liposarcoma. And then other areas here show these clusters of epithelioid cells that also have this eosinophilic, reticular, and fibrillary cytoplasm. In fact, if you look at the top part of this image, you can also see some spindling. So because of these findings, additional markers were done. This is smooth muscle actin, which seems focally positive, and this is HMB45, which also shows multifocal patchy reactivity. For some of us, this might be quite positive. For others, it may not be enough. But what does make this case, or what does make this diagnosis 100% confirmatory, is GPNMB. So this was diffusely strongly positive, and in conjunction with the histologic features and other markers, this case is a PCOMA. So here's a case of malignant PCOMA that has significant nuclear pleomorphism and also multiple mitotic figures. And even in malignant PCOMAs, GPNMB is really useful. If you do HMB45 in these tumors, you may not really see much. There is some focal reactivity that's weak, but GPNMB does produce that strong diffuse staining pattern that's really helpful in the diagnosis. So it's got a weird name, glycoprotein non-metastatic melanoma protein B. This name came up because it was first discovered in a melanoma cell line, which the authors called B, and they found that GPNMB tended to be overexpressed in the melanoma cell line that had lesser incidence of metastasis compared to the other group. But now we know that it's not really true, and it can be found in melanomas that are widely metastatic or have high incidence of metastasis as well. So anyway, so this is a transmembrane glycoprotein that is preferentially overexpressed in tumors that have mTOR pathway activation. And this activation may be due to loss of the TSC1, TSC2 genes or direct mTOR mutation, which in turn upregulates the microphthalmia transcription factors, TFE3 and TFEB, which directly drives GPNMB gene expression. So this is one of those secondary overexpressed gene products that we can detect using targeted immunohistochemistry. So if used in the right setting, it has high sensitivity and specificity for the diagnosis of PICOMA. And again, as we saw in the other markers like MDM2, you should be seeing diffuse strong staining in the tumor. We often see this type of staining for GP and MB. This happens to be a case of clear cell renal cell carcinoma that shows some patchy reactivity for GP and MB, and we don't typically call that positive. Other tumors, there are many other tumors that can be positive for GP and MB, but they don't really relate to soft tissue bone pathology. You can have several aggressive carcinomas or, of course, like melanomas that are positive, but you can always use simple markers that help you rule out GP and MB, or sorry, help you rule out PICOMA in these cases. Of course, translocation-related RCCs are strongly positive for this. The only tumor in the soft tissue world that can show the same amount of reactivity for GP and MB as PICOMAs is the alveolar soft part sarcoma. And here's a case of ASPS that is somewhat atypical and may, in some sense, mimic a PICOMA. So here, instead of the typical alveolar morphology, we see more of a sinusoidal or trabecular growth pattern of this tumor, abundant eosinophilic cytoplasm, and you can see perhaps some fibrillary nature of the cytoplasm as well. So PICOMA could potentially be in the differential diagnosis of a tumor like this. And if you do GP and MB, it's going to be diffusely strongly positive. So how do you make the differential diagnosis, or how do you make the right diagnosis in this situation? ASPS, as you know, typically occurs in young women as a deep thigh mass. PICOMA can occur anywhere in the body. That's somewhat helpful, but not really that helpful. But the histology in typical cases of ASPS should look like this. An alveolar fallout, central fallout of the cells creating an alveolar morphology. And these have abundant eosinophilic cytoplasm with prominent nucleoli. And of course, unlike PICOMAs, these are typically negative for melanocytic and myeloid markers unless you have a TFE3 fused alveolar soft part sarcoma. And there's also some use for the old special stains. PAS tends to have these peculiar cytoplasmic, crystalline or granular deposits that are diastase resistant in cases of alveolar soft part sarcoma that has not been described in PICOMAs. And of course, they have the specific fusion. So finally, case 5. This is a 53-year-old female patient who presented with hip pain, and the radiologist on MRI found abnormal marrow signals in the iliac bone, just centered around the acetabulum. So you can see here, the femoral marrow is quite different. Femoral marrow is normal, and it's quite different from the iliac marrow over here. So they provided a differential diagnosis of either a subacute fracture with edema and associated reactive processes versus a marrow infiltrative process. And a differential diagnosis for that would include Mets myeloma, lymphoma, as well as infection. So again, we were lucky enough to have an open biopsy for this case. However, the open biopsy is not that satisfactory. So most of it was just blood. And there are some fragments of both trabecular medullary bone and cortical bone. Another fragment did show something, but it was basically nuclear streaks and degenerated nuclear material with crushed artifact between these marrow bone trabeculae. Not really helpful in making a diagnosis. Another section, again, just showed hemorrhage with probably some hematopoietic elements or maybe some inflammatory cells. And there are, if you notice carefully, some darker nuclei here, maybe hematogones, maybe not. It was really hard to say. So multiple IHC markers were done. Heme pathologists reviewed it, and they said it was not really a lymphoma. Some basic surgical pathology markers were done. All of those were negative. So it was this case was actually signed out as non-diagnostic, but then we did in retrospect do NKX 2.2 in this particular case. And you can see, even though the tumor does not have too many cells in it, or the biopsy sample does not have too many cells in it, whatever is present is strongly positive for NKX 2.2. And this is true even in areas where you had crush artifact. NKX 2.2 is really strongly positive. So extremely helpful even in situations where you don't have good diagnostic material on H&E stains. And this case did show EWSR1 rearrangement on FISH testing. So this was Ewing sarcoma. Even though we got very little material, we were able to confirm the diagnosis for appropriate therapy for this patient. So what is NKX 2.2? It's the direct downstream target of tumors that have the FET ETS family fusion. And EWSR1 is one of the genes in the FET family, and FLI1 is one of the genes in the ETS family. You can have other variations too that do upregulate NKX 2.2. And this is actually a neuroendocrine transcription factor that does have, again, high sensitivity and specificity for Ewing sarcoma if used appropriately. Typically in Ewing sarcoma, NKX 2.2 should show a robust, diffuse, strong staining pattern. There are other tumors that can be positive for NKX 2.2. Outside the world of soft tissue sarcoma, you can have, in particular, GI neuroendocrine tumors that are strongly positive for NKX 2.2. Olfactory neuroblastomas can do the same. But when you're considering just soft tissue tumors, there are only two things that you need to be concerned about. That's going to be mesenchymal chondrosarcoma and EWSR1 NFAT-C2 sarcoma. So if you look at mesenchymal chondrosarcoma, it shows pretty much the same characteristics that you would expect to see in Ewing sarcoma in many foci. You might see some stack-on-like blood vessels. That's not too common in Ewing sarcoma, but it doesn't really make too much of a difference. If you apply the immunohistochemical markers, NKX 2.2, as I mentioned, is going to be diffusely strongly positive, and CD99 is also going to show you that typical diffuse transmembranous staining pattern that you see in Ewing sarcoma. So how do you make the distinction? Mesenchymal chondrosarcoma is more common in soft tissue. That's somewhat of a soft clue. So about 50% of mesenchymal chondrosarcoma actually occur in the soft tissue. And histologically, if you observe carefully, even in biopsy specimens, you should be able to come across some foci that show cartilaginous differentiation. It may be really immature cartilage, maybe somewhat of a myxoid change in the background that gives you a clue. In some cases, you can see more mature cartilage and even bone formation in mesenchymal chondrosarcoma. That's really uncommon in Ewing sarcoma. And MCS also has spindling that's more common than in Ewing. And as I showed previously, it can have those stag-on vessels. And unlike most Ewing cases, MCS can show muscle markers, skeletal muscle markers, either desmin, myogenin, or MyoD1. You can see focal MyoD1 positivity in this tumor. And of course, as you know, MCS has a distinct translocation. In more than 90% of cases, you see HEY1 NCOA2 fusions. And then lastly, I want to talk about EWSR1 NFAT-C2 sarcoma. This is a case that we came across recently in our practice. Here we have more or less a myxoid background with some fibrous tissue and these cells that are arranged in cods and clusters. It basically looks like a myoepithelioma, or if this is going to be a large mass, and if you're thinking of sarcomas, you'd be thinking probably of extraskeletal myxoid chondrosarcoma. And then higher power shows you a higher NC ratio, again, embedded in that myxoid background, not too much atypia as such. So this case was, again, strongly positive for NKX 2.2. On the outside, I think this had a diagnosis of actually extraskeletal myxoid chondrosarcoma, but we did the NKX 2.2 and it was strongly positive. And then subsequent FISH test and genomic sequencing did show that this was ENS and not Ewing sarcoma. So how do you make a difference between these two? The morphology actually appears quite different unless you get a case of ENS that's going to be very cellular, that it obscures the myxoid background and the architecture of the tumor cells. In those cases, it might be a little bit more difficult, but typically you see these CODs and nests in the myxohyalin stroma that, again, as I mentioned previously, might bring up a differential diagnosis of myopithelioma. In some areas, they can be spindle with some collagenous stroma in the background. You could be thinking of a perineurioma or a low-grade fibromyxoid sarcoma here. And the problem with these cases is many of them tend to have epithelial marker expression. And in this particular case, EMA was actually diffusely and strongly positive. But unlike myopithelial tumors, these are negative for S100. And unlike low-grade fibromyxoid sarcomas, these are negative for MUC4. And then the other thing that's really useful for the diagnosis of ENS is that the fish shows a peculiar pattern. It not only shows rearrangement of EWSR1, but it also shows amplification of the phi- probe, which you can see over here. I don't know how well it projects, but there are multiple red signals with a separated green signal here. So that's a peculiar pattern that's been consistently observed in ENS that helps in the diagnosis. So we basically looked at 5 different cases where in routine practice that these next generation immunohistochemical stains were extremely helpful in coming to a right diagnosis. And in conclusion, I want to say that, as most of you know, soft tissue bone pathology is an extremely challenging specialty. It's a niche specialty that's only practiced in a few centers across the country and the world. And these tumors are quite rare. Only 1% of all cancers are soft tissue tumors, and they're also quite diverse because you have more than 200 or almost 200 entities that can often have overlapping histologic features. So not only has one got to keep track of all these, one also has to keep track of the evolving genomic, transcriptomic, and metallomic classifications in these tumors. It's an extremely difficult task. And with that, you also have high costs. If you do want to accurately molecularly stratify these lesions, you have to deal with the cost, the long turnaround time, and in many centers across the world, you don't really have the infrastructure or the expertise for all these for performing all these molecular methodologies. So in that setting, these novel IHC markers are extraordinarily transformative for the practice of soft tissue bone tumors because, as I just showed via these examples, they have a high degree of specificity and sensitivity if used in the appropriate context. And like all IHCs, the cost is low, the availability is fairly easy, and the turnaround time is basically 1 day. And then lastly, some of these in the future could also be used in the context of conformational proteomics for targeted therapy. That's because, as I keep saying, protein is the king, because like the targeted therapy is against the protein and not against the gene. You may have NGS testing showing a gene that's mutated or not, but you actually need to show the protein expression present or absent for the targeted therapy to work, because that's what it targets, not the gene. So with that, these are my references, and thank you so much for your attention. Any questions?
We are a bit over time, but we have time for maybe one question. Yes, but
I just have a quick question about GPNMB in the gynae setting. I'm just thinking of a recent colleague's case where it was morphologically ambiguous, what looked like a malignant PEComa with lineage markers sort of suggesting that. And then I guess the question being what your thoughts would be about its performance in the gynae setting, especially given like a high-grade carcinoma could potentially express it. And then I guess how that would compare to the NGS panel for PEComa, and whether, if you know, that would still get drug clearance if you sort of prove it with that IHC marker.
For the last part of your question, I don't think it's actually used as a predictive marker, so I don't think that's possible. And as I mentioned, like GPNMB is not completely specific. unless you use it in the appropriate context. It has to be diffusely strongly positive. In fact, the case of malignant PEComa that I showed, which diffuse GPNMB reactivity, was actually from the uterus. It was a uterine PEComa. So it is useful as to what other tumors in the uterus could be positive. The main differential is going to be a high-grade leiomyosarcoma or endometrial stromal sarcoma. In our experience, these tumors are not positive for GPNMB in this fashion, but could one of them have an mTOR pathway mutation, and could that upregulate GPNMB? Perhaps, but large studies with more than 1,000 cases were performed, and I'm not completely sure how many of those included uterine tumors, but it's specific for PEComa in the setting compared to the others. But like, we have the world's expert, Dr. Paul here. Maybe he has better experience with this. Do you have any comments on that?
No, I mean, the actually GPNMB at Mayo has largely been driven by the GU people. So, like Shauna Gupta has done a lot with it. And no, I mean, I think what you presented is basically the same as our experience. I think with the GYN stuff, the problem with any new antibody is until you start testing it on all the things you're interested in, you don't actually necessarily know. I mean, the other more general comment I would make is that, as you've said, this stuff is transformative and it is applicable to lots of other practices. The problem is that, as with any antibody, if you run it too hot, if you epitope retrieve it incorrectly, you can get a lot of things to stain in a lot of settings. And that's the one concern I have, is that we're sort of opening up these exotic diagnoses to places that may not necessarily know how to use. I mean, that's a problem with any antibody, but I think the specificity of all these things really depends on doing them. I mean, it's a problem with any antibody, but I think it becomes a bigger problem as we expand the group of people who could do it.
And for a usual lab to work it out, you need appropriate control specimen, and for these rare